All right. It's not showing up here.
No, I'm knocking it out.
Well, Al's gonna find out this year, I'm not the only person. Really? There's a lady that's with
Really?
Okay. So are we ready to get started? So we got through a lot of material about the shoulder last week after the test. And we talked a lot about assessing the shoulder. And now we're going to move into the different diagnoses that you would treat with the shoulder. And then some treatment interventions with the shoulder. Any questions about assessment before we move forward? Are we good? If anyone needs an extra copy of the PowerPoint, I have extras up here. And the copies for the next lecture are being copied in right now. So will be out in a minute. So this is an algorithm from your book, and it just helps you to figure out, because when people have shoulder pathology, very frequently they say it hurts right here, because this is a referred pain area. So very frequently it hurts right here. But then when you start evaluating them and start having them pinpoint things and you're finding painful points of palpation, this can guide you. If it's lateral pain on the lateral side of the glenohumeral joint, then it's likely one of these types of situations. Again, we don't diagnose pathology, right? But when we get a diagnosis from a family doc of shoulder pain, right, we have to figure out what's going on, right? Not that we're diagnosing, but we're trying to figure out which particular part of the anatomy is disrupted or not, or inflamed, or whichever, right? So if it's lateral pain, it could be rotator cuff tear, impingement, or a deltoid strain. If it's posterior pain, which from my experience is very uncommon, could be a dislocation or a subluxation. And then anterior pain, more options, right? But when we're looking at anterior, it could be at the SC joint or the AC joint, which you can palpate those joints individually and palpate for discomfort. You can look for arthritic changes at those joints. And usually it's very obvious and compare right to left, or maybe it's bilateral, but palpate the joint if you're thinking it could be an SC joint or an AC joint problem. And then also your biceps tendon is very easy to palpate at the, so that's going to be pain more here, you know, right in the front at your biceps tendon. And if you resist your biceps and flex your shoulder, you can kind of feel it here, and you can palpate there. And if that's tender right in here, dig in there with your patients, and that could indicate some sort of biceps problem. And then other could be a clavicular injury like a fracture, or it could be subluxation or dislocation. But from my experience in working with shoulder pathology, very common impingement and rotator cuff problems. Very, very common. And very common biceps tendon pathology, and very common arthritic changes in these joints. When we look at things like dislocation, that's when people have like a disruption of their labrum. Remember how we talked about that structure, that little suction cup that holds the head of the humerus onto the glenoid fossa? People describe things like, and they say the same things. They say things like, I feel like my shoulder's gonna pop out. That's what they say. Like, I feel like my shoulder, if I move too far, like it's gonna come out. They describe that. And that's your red flag, like, hey, I'm worried about a labrum pathology, but they describe that. My friend's son had an injury from some sport, and she called me, and I never even saw it, and she called me and she's like, Devin hurt his shoulder, I don't know what to do, he can't move his shoulder very well, he's going to PT, but he's not getting any better, and of course he's not going to OT, right, because they take all the shoulders. He says he feels like it's going to pop out. She just told me this on the phone. he's got a labrum tear. He's got a labrum tear. Take him to an orthopedic surgeon, and she did, and he had an MRI, and he had a labrum tear. But that's what they all say. I feel like it's going to pop out. They describe that. So this just helps you in trying to figure out, what the heck could be going on, because very commonly we get these referrals from family docs who, again, have to worry about liver functions and dialysis, Coumadin levels, and shoulder pain, and back pain, and knee disruption, and cognitive mental health issues. I mean, they have to know about everything, right? So they come to us looking for help. So we're going to go through some different diagnoses, and frozen shoulder is one diagnosis that you'll see out in the community for sure. The big thing is it's idiopathic. So there's not usually a trauma that occurs before the pathology begins. Idiopathic. It comes out of the blue, right? The pain is diffuse all over, not so pinpoint that it hurts right here or it hurts right here. Diffuse symptoms. With this, there's a limitation in passive glenohumeral joint motion. So if there's a limitation in passive, will there be a limitation in active? Yes. They're stiffness. So if you get a patient with poor active and good passive, you shouldn't be thinking frozen shoulder, right? Bad passive, bad active. It's a joint problem, not a strength issue. So with this, the capsule becomes the capsule within the shoulder. In different positions, the capsule overlaps onto itself, and that gets scarred down and thickened and shortened from not moving the shoulder, that adaptive shortening that occurs in our soft tissue. And this is the typical areas of loss of motion: flexion, abduction, and external rotation. Because if you think of it, the glenohumeral joint, the only thing that's left is that position of protection and guarding, right? Adduction and internal rotation. They hold their arm in like this. Painful, they don't want to move it, stiffens up, they don't move it, gets more stiff, and their shoulder becomes frozen. It's very common in middle-aged women. My sister-in-law just had frozen shoulder and insidious onset. Just comes on over time.
Do you see this with any, have you noticed a pattern with people who do certain occupations get this more?
No, because my sister-in-law actually got it after she retired, but she was taking care of 2 grandchildren at home. But it's very common in women. I've seen men, though, with it. Middle-aged problem, not a young person's problem. More of a middle-aged, from my experience. I don't have the demographics in here, but maybe your book talks about age group. But I usually see it with people 50s and 60s. And I would say more, from my experience, more women than men. I don't think it's related to an occupation.
Is it ever related to a neurological incident?
So if you had a neurological incident and your shoulder got stiff because you didn't use it, but I would say if it was related to a neurological incident, it would be more related to a shoulder-hand syndrome.
Well, was that a client that had an anoxic brain injury, and I wasn't familiar with this, but then my clinical supervisor evaluated her, and she had all those symptoms to a T, and it happened after she had the brain injury, so I didn't know.
Right, but with the brain injury, it could have caused a disruption in tone to that other side, or depending on where the brain injury occurred, with an anoxic injury. And then, because of decreased, either decreased tone or too much tone, stiffness occurs. So this is more idiopathic. It's not usually associated with a neurological issue or a trauma, a fall, a fracture. Those all are stiffness secondary to another problem. This would be idiopathic, just comes out of the blue. All of a sudden, my shoulder starts hurting, so they start moving it less. Comes out of the blue, and then it gets extremely stiff, and they can't do things. Yeah. So with the frozen shoulder, there are phases where at first it's painful, then it gets stiff, and then possibly it could thaw. I haven't seen a lot of thawing happening. I would say most, but then again, I wouldn't see those patients, right? The patients that I see usually have this painful phase, stiffening phase. They have this problem with motion, so they go under anesthesia. The doctor does a manipulation, sends them to therapy the next day to get moving. So I don't know if this just isn't as common, or if I don't see those patients because they don't end up coming to therapy because they resolve on their own. I don't know. But yeah, in the beginning, you could be thinking, oh, they might have a rotator cuff problem. And my good friend right now, she came to me and she said, oh, my shoulder's hurting. Where is it hurting? Right here, you know? And so I evaluated her, and I'm not diagnosing her, but from what I understand, I believe she's having more of an impingement problem. But my first thought was she's 49, and I was thinking of frozen shoulder, because she said nothing happened, this kind of came on over time, which could happen with impingement as well, but it could have been this. So we're so she went, I said impingement, she went to the doctor, I gave her exercises to do, which she was not compliant, and then it was still hurting, so she went to the doctor and impingement. But this can mimic a rotator cuff problem or an impingement type problem in the beginning because they're so painful. But then big stiffness occurs, big stiffness. And so another thing, in this painful phase, if you put them out, they would have full passive range of motion because they haven't moved into the stiffening phase yet. Here, if you put them out stiff, can't move them. But if during this phase, if they're not getting better and they're not starting to thaw, the physician will put them under anesthesia, do a passive manipulation, and then they come to therapy after that. And they need to be seen usually 5 to 6 days a week initially, get them on the right track, and then decrease their frequency of treatment.
So do they just randomly start to thaw, or is that as a result of treatment?
I have seen people that were treated with frozen shoulder, but I haven't seen anyone that was treated successfully. So from my experience, I can't answer that thawing phase. Dave, do you have any feedback from your PT clinic? Seen any frozen shoulders that thawed?
No.
I'm sure you see a ton of shoulder pathology.
Yeah, we see frozen shoulders. They usually end up getting a manipulation after surgery.
Yeah. Usually they end up getting manipulated. They under anesthesia, manipulated, come back to therapy. From my experience, therapy first has been very successful, unfortunately. Okay. So, like with that algorithm, we're always differential diagnosing things, right? There's a long grocery list, just the same things that were in the algorithm pretty much, of what it could be if it's not frozen shoulder, right? Lots of other options. But let's look at the rotator cuff. The rotator cuff are the sits muscles. I always try to find different ways to try to memorize things, right? S-I-T-S. We sit down, right? But these are the muscles that make up the rotator cuff. And this shows the anatomy. If you want to work with shoulders, you should know where they start, where they stop, where they are on the shoulder. But the big picture thing that you'll have to know for this class is what is the purpose of the rotator cuff muscles, the four muscles of the rotator cuff. And a big thing is they stabilize that humeral head, which I think we talked about last week, during overhead motion. Okay? So, and they increase the power of the deltoid. But the biggie thing is they stabilize the head of the humerus during upward rotation, which keeps that subacromial space, which prevents things from impinging, right? So if I have a diagnosis of impingement syndrome, what should I be looking for right off the bat? Supraspinatus. But I'm thinking I have a problem with rotator cuff pathology because it's two problems. I have a problem in my subacromial space, which is pinching on my supraspinatus, right? But the root of the problem, the root that caused the impingement, is weakness in my rotator cuff muscles. And specifically, it's going to be your external rotators play a giant role in this. So, if I have someone that comes with a diagnosis of impingement syndrome or rotator cuff pathology, what is the first thing you would think that I would want them to avoid? Not external rotation. I want them to do this 100 times a day to strengthen overhead movement, because they're not stable. They're not stable. So we do not want them reaching overhead, if they can avoid it, until we get the rotator cuff stronger to stabilize the humeral head for overhead reach. So no, if they can avoid it, now there's different jobs where you don't have a choice, right? Electricians are always up overhead, construction workers, all that stuff. But try to find another way if you can raise the person up so they're not reaching so high. But we want to really decrease overhead function. So pathology of the rotator cuff is frequently caused by impingement syndrome, and that muscle would be what? Supraspinatus. Yeah. So frequent supraspinatus tear caused by impingement, which was a root cause by instability of the humeral head, which was the root cause by rotator cuff weakness. And other pathology, you know, our posture and the things that we assessed last week, looking for, you know, that forward rounded posture, a scapula that does not upwardly rotate. All of those things lead to the root of impingement syndrome, which then is the root of rotator cuff pathology. And we had a patient in the clinic, I think Heather treated, who's Heather's partner in my clinic?
Sarah.
Oh, neither one are in this class. So we had a patient in level 1 that came in, and she was actually a fieldwork educator for one of our students who was out on level 2. And she went, she was going to therapy. She lived in Lansing, and this student was in Lansing, and the therapist, who's an OT, is a pediatric therapist, right? And she's working in Lansing, and our level 2 student is there, and she's complaining about her shoulder. So level 2 student says, you should go see, you know, go see Nancy at the clinic. And she's like, well, I'm going to PT. And so I said, well, I'm on the phone, like, what kind of things are they having to do in PT? Her diagnosis is shoulder pain, and they're having her do overhead resistive activities in the clinic, weights overhead. Okay? So I'm like, just come in for one visit. She drives from Lansing, and she brings her coworker, who's also an OT, with her. So poor Heather and Sarah have 2 licensed OTs that they're working with. So it was kind of stressful for them, but they did great. And what she ended up having was shoulder pathology related to impingement and a partial rotator cuff tear. So she had a diagnosed partial rotator cuff tear that was diagnosed either from a CT or MRI, and the PT was having her do resisted overhead activities. Makes no sense from what you know, right? The funny thing is that she said, yeah, when I was in OT school, they evaluated my shoulder, and where's Allison? And it was doing all kinds of funny things, but I really didn't do anything about it. And now she's working in a pediatric gym where she's hanging up swings overhead and lifting kids overhead and all that stuff. And now she has pathology. So. All right. So there's lots of classifications of rotator cuff tears. And we don't decide any of this, right? This is just here for you to understand when you have the luxury of finding out, or your patient tells you, I have a massive tear, or a partial, you'll know kind of what we're talking about. And then sometimes they say small, moderate, large, or massive, so you kind of have an idea of what we're looking at here. But this degenerative tear is that one that's related to that impingement syndrome, where the wear that occurs over and over again with that decreased subacromial space creates a tear in the tendon. But you can also have something traumatic, a fall with an outstretched arm, motorcycle accident, bike accident, car accident, anything high speed of injury can happen. Sometimes when the repair is too great, sometimes the doctor will, even if they have a partial tear, they'll send the patient to therapy, try therapy first to see if they can get their symptoms under control without surgery. If the tear is too big, they'll do surgical repair of the tendon, of the rotator cuff tendon. So if that's the case, knowing what we've already learned in this class, would you start with active range of motion or passive range of motion? Passive range of motion. Because active range of motion is activating the tendon, which could pop the tendon, right? And many times you'll see people after rotator cuff tear with those slings with like a pillow underneath, which makes sense because if it's a supraspinatus tear, is my supraspinatus on a slack up here or down here? Up here. Because look at my shirt even, right? It goes right across the superior portion of my shoulder. So they put that on there to take stress off the tendon repair, to put it on a slack to allow it to heal. Sometimes they'll have to surgically decompress and remove the acromion head, and so to take pressure off that, so that could be a surgery that occurs along with the rotator cuff repair. To decrease likelihood that would happen again.
So when a doctor sends a patient in for a partial tear to get therapy before possible surgery, so then the goal is that, is it common then for they come in for therapy and that solves the problem? They don't have to get surgery?
It can, absolutely.
Because then the goal would be to then increase strength in that area?
So if someone had impingement syndrome, developed a supraspinatus tear from wear and tear, partial tear, sent them to therapy, what are we going to focus on? What's the root?
Weakness.
We want to heal the supraspinatus tear, but what's the root?
Weakness in the external
Weakness in the external rotators that are stabilizing the humeral head as we reach overhead. Postural instability. We're going to work on postural symmetry. We're going to work to make sure that scapula is upwardly rotating. We're going to strengthen the scapular stabilization muscles and the shoulder external rotators to stabilize that humeral head when I reach overhead, so it quits wearing and tearing on my supraspinatus. If I don't fix the roots, the tendon won't heal. Does that make sense?
Because if you fix the roots and you're allowing them to heal, even though you still have to use them. And how long does a tear take to heal?
Well, it depends, on how bad, because you aren't going to fix posture in a day, right? You got to fix the root of the problem first. As we all are probably like sitting up, or standing up a little straighter, You got to fix the root. Get the posture corrected. Get the strength in the external rotators and the scapular stabilization muscles. Make sure the scapula is upwardly rotating appropriately. That's what you have to fix. Avoid overhead activities, for sure. No strengthening overhead. Never, never, never. Then you are charging them for it to do harm to them. And that's what was happening to this OT. All right. And she knew, this is not right. I'm having so much pain in therapy. This does not seem like this is what I should be doing. So, all right. But the big take-home message too is that rotator cuff pathology is super, super common in people, and it's an aging issue. It's an aging issue. And so if you look at the people hospitalized between 50 and 60 years old, 30% would have rotator cuff pathology. And then if you look at people on autopsy, 90% to 100% of patients had a defect on autopsy of their rotator cuff, but many of them, 40%, were asymptomatic. But it's a very, very common problem with aging. Because what happens to us as we age? I'm hoping to not do that, but we get rounded, right? Our posture decreases. We spend more time sitting, right? All of those things lead to this type of dysfunction. Our overall body circulation is not as good, and we can't recover from tears and things that happen in our body. So if you work in a nursing home or home care, you are going to see people with rotator cuff pathology. And assessing things like their wheelchair posture. All of those things can make a big difference on their shoulder motion. Because it's very hard to dress independently when you don't have good rotator cuff function, right? It's very hard to do home management tasks, reaching a cup overhead, or getting a shirt out of my closet, or doing my hair with shoulder pathology. So you will absolutely see it, and you should know how to treat it and what to do. But this is a typical protocol for rotator cuff repairs. But it's going to be different based on the physician, based on the patient. So what you should do if you get a patient post-op, this is a patient that you could muck up, all right? If you get a patient post-op with rotator cuff tear and you start them doing active range of motion too early, their repair could tear. If you put them in a wrong position and they had a labrum repair, their labrum repair could tear, and now they're dislocating again because of what you did in therapy. So these are diagnoses that you want to make sure you know what you're doing. So in the beginning, your book talks about E-stim for pain management. I'm not a big E-stim person, maybe because I personally don't like the feeling of electric current, but I have such little time with my patient. I don't want to spend 10 minutes of my time, if I have 30 minutes, with my patient sitting with E-stim on. If they need E-stim, which I have not seen a huge thing that it's very effective for pain control, but if I do, I would get them a home unit and not waste my precious minutes in the clinic having them sit with E-stim on their shoulder. I want to get them moving, right? I want to address joint stiffness with my precious 30 minutes that I might have with that patient. I'm not going to put them on E-stim in the clinic and waste 10 minutes of my time. Pendulum exercises, and we talked about these before, the elephant trunk. We talked about those last week, right? So the rotator cuff is not working to move their shoulder. If you let a post-op rotator cuff repair do this as a pendulum exercise, that's active range of motion. We want passive range of motion in the beginning, right? The weight of my body moves my arm, like the head of an elephant moves its trunk, right? Same way. At day 3 to week 3, passive range of motion, consider limitations per protocol. So if someone has a dislocation anteriorly and with a labrum tear, they may not be able to go into external rotation and abduction at the same time. That's going to be in the protocol, okay? So usually the doctor would indicate that on the script, and if you're not sure, then you call and ask, all right? And you don't have to speak to the doctor. You can call and talk to the nurse. They'll relay your question and get it clarified for you, but it's better to ask. than to do the wrong thing and muck something up, right? And then at week 3, we start active range of motion. Does that make sense to what we've learned about tendon healing? Right? Day 21, the tendon gets stronger. Week 3, we start active range of motion. And then week 6 to 10, we start doing strengthening. And isotonic would be that concentric and eccentric contraction when muscles lengthen and shorten. Isometric, remember, is strengthening without movement. Like a plank, a push-up is isotonic. Concentric and eccentric contraction. Okay, we good? All right. Sometimes a rotator cuff can be so bad that it cannot be repaired. And these patients are also sometimes sent to therapy. Because remember that big, long grocery list of all the muscles we saw last week? There's multiple muscles that do each function. So we're going to maximize what we can, get the most range of motion and strength. And sometimes I am amazed by how well patients can do with an unrepairable rotator cuff repair. So don't think like, well, why would they send you to therapy? They couldn't repair your rotator cuff. They send them to therapy and you do the best you can to get the most motion, strength, and function that you can get. And it's sometimes very surprising what they can get, utilizing other muscles to achieve the same work. So, and we're gonna get range, we gotta get the joint stretched out, right? We need to get active range of motion to whatever they can get to. And then we want to strengthen the glenohumeral joint, and we cannot forget those scapular stabilization muscles that we need to address. You got to strengthen, you got to address the whole upper quadrant, not just the glenohumeral joint, or you're doing only half of the whole picture. Okay? That's rotator cuff tears. And usually each physician will have a specific protocol, and you can just call and speak to the front desk at the doctor's office and say, can you send me Dr. Jones's protocol for rotator cuff tear with supraspinatus tear, and they will send it to you. If you're dealing with a clinic like Orthopedic Associates of Michigan, they have a therapy clinic. You could even call the therapy clinic and ask them for a copy of the protocol. Maybe you're more rural and the patient lives out where you live, and so that's why they're not being seen by their own therapist. So therapists are very, good about sharing and helping one another, just like you do in class. That continues when you leave. Your support system is in this room and here, in the office, but it's in this room, so you'll lean on each other with questions about cases and things like that. Okay, so let's move on to impingement, which we've already talked about a little bit, right? This narrowing of that subacromial space, impingement of the rotator cuff, and this is really caused by this malpositioning problem, or a problem with the lack of upward rotation of the scapula. There's some other root that caused the impingement. And then this can lead to rotator cuff tear if it's not addressed, or partial tear, or complete tear later on if it's not addressed. So then on to this glenohumeral instability, and this is when we're talking about more of a labrum issue, okay? These are the patients that said, I feel like my shoulder is going to pop out. They have an MRI, diagnosed with shoulder instability from a labrum tear. Labrum is repaired, okay? And there's all different kinds of surgical repairs and directions of instability. So we're not going to go into a huge amount of detail for this class. And if you're working in a clinic, say even if you're on level 2 field work in a hand clinic, okay, they're not going to have your first patient be a flexor tendon repair, right? They're not going to give you that first. They're going to give you someone with tendinitis, right? Someone with maybe a fracture, that's moving along. They're not going to trust you first out of the, thing with the rotator cuff, the flexor tendon repair. Same thing when you're working with shoulders. You're not going to get an instability patient out of the gate. They may never trust you with that. They may never trust you at level 2 with a tendon repair. It depends on how things are going, right? But you can read through this. This stuff is not going to be on the test because it's more advanced. But this is here for your information. But there can be directional instabilities based on where the labrum disruption occurred.
Right.
And then here are some names of surgical repairs. So if you get a script and it says Bankart repair, right? So if your first job out of OT school, you've been at OT for 3 days, look at the scripts before. If your mentor's on vacation, look ahead. You see you got a new patient on Thursday, today's Tuesday, they know something about that person. Your mentor's on vacation. Find out what it says. And if it says Bankart lesion or repair, you better get some help, right? Before the patient gets in. Same thing with flexor tendon or extensor tendon. You can't handle that on your own without a mentor in the beginning. It's a hard thing. Here is the typical protocol. But again, it makes sense because in the beginning, look, external rotation to 0. They're not letting it come out at all, right? Because think about it, right? Instability. They're not even letting you abduct very far to 60. So they're going to limit abduction and external rotation primarily. Sometimes they'll let you flex to greater than 90. Sometimes getting my belt buckle. Sometimes they'll let you flex greater than 90. This is the protocol from your book. But then again, look, week 3 makes sense, right? We're going to start to add a little bit more, right? Our tendons are getting stronger. But again, look, external rotation to 45. This is it, right? These are not patients that you want to stretch out like this because you don't want it. You want it to stay tight a little bit. Because what do we have to do functionally like this? Nothing, unless you're a baseball thrower. And if you have instability problems, you probably can't be a pitcher. But this shows, and we're going to talk about some of these types of things when we talk about treatment in a minute. So here is another protocol with instability. But that basically goes through tendon injuries to the shoulder, to the glenohumeral joint. Okay? I know it's a lot, right? So we're moving on to humeral fractures, right? What is the nerve we're going to think of when we think of humeral fracture? Radial nerve, right? We're going to evaluate, if I have a patient with the humeral fracture, I'm going to manual muscle test what muscles? Wrist extensors, that's a quickie, right? Supination, elbow extension, right? MP extension, because it's the EDC, right? Thumb extension. But these are very common with that foosh, fallen outstretched hand. And many times these are treated non-operatively, just conservatively, right? One thing that they do use with sometimes to stabilize these fractures is called a humeral fracture brace, where it's just a cylindrical splint that wraps around the humerus. And you can't let it cut up into the axilla area, and you have to wedge it out for elbow flexion. But you make it around, and since it's cylindrical, it has to overlap. Or you could do clamshell, or there are some prefabricated ones that you can purchase, okay? But if I'm going to make a cylindrical splint, what's one thing I should be worried about in the fabrication of that splint when I'm making it and it's overlapping? What's something I should consider or think about?
Airflow, skin integrity stuff.
Not really that. I'm talking about having a big problem during the fabrication process.
Taking it on and off.
If it sticks together, getting it on.
Huh?
If it sticks together, getting it on.
Does this
Yeah.
material stick together? Right? If I make a splint that overlaps and that material does not have some type of a solvent on it to keep it from sticking together, I'm not getting that baby off unless I cut it off my patient. And do you want to use a really thin material, I think, for this? So you want to put something to keep the splinting material from sticking to itself. Very, very critical. That would not be good, right? You wrap it around, you wait till it gets hard, and then you go to take it off, and it's stuck together, right? Wet paper towel, put it between the layers, will keep it from not sticking. Okay? This is too much material for a lotion or Vaseline to use. Wet paper towel you want to use. This is also a common because it's very, very frequently related to falls, so it's common in older people. So if you are in a skilled nursing facility or you're in home care, you will likely see someone with a humeral fracture, not just a hand therapy world. More common in women. And here is the biggest thing. Greatest range of motion occurs in 3 to 8 weeks post-fracture. So do we think we keep these people immobilized for a long period of time? No. If you are seeing a patient and they're 4 weeks post-op and you don't have orders for range of motion, you should ask. If you don't, you're going to miss your whole opportunity to get motion back if you wait for the next follow-up appointment. Remember, if you're working in a skilled nursing facility, the nurse is going to get weight-bearing orders, right? They're going to find out if the patient can use it to push up from a chair or during transfers to the commode. That's what the nurse wants to know, right? The nurse checks the patient in, has the contact with the referring physician. That's what the nurse wants to know, right? They're not going to be moving that shoulder to work on range of motion, right? That's what we're going to do. So if we don't know, if we only have weight, non-weight bearing does not mean that the patient cannot move, okay? So if you don't know the orders, if it says no range of motion, then that means no range of motion. But if it only says weight bearing, you don't know if you can move it, so you have to call and find out. And in the beginning, new graduates are very apprehensive to call the physician's office. It's scary, right? That's why I like the students in my clinic to do it, because if you do it a couple times, you realize, hey, that's not so bad. No one's going to reach through the phone and strangle me, right? It's not so bad. So you just got to call. So this is like if you remember one thing about this lecture today, this would be what I would ask you to remember. Because it's so important when you get out there in the field. If you don't take the initiative to get the patient moving, you're going to miss your opportunity. And your patient's going to have big time stiffness and big time pain and never get their shoulder range of motion back because you didn't want to call the doctor. Is that a guilt trip or what? Right? But, you know, I was talking at OT 2020 yesterday. I went and was a guest lecturer for the Honors College section of OT 2020. And I was talking about a patient, and I know I may sound a little bit harsh, but you guys have a responsibility as a therapist, right? We're not making ketchup here, right? Does it matter if my ketchup doesn't really have the right ratio of sugar to whatever goes in tomato? It may taste different, but am I really truly impacting someone's life? Right? We have a huge responsibility when we leave here, right? If I choose to not make the call, and I say, oh, you're non-weight bearing, when do you go back to the doctor? 6 weeks. Great, we'll ask when you go back. I'll send a note. You just did a huge disservice to your patient, right? So, and I think I've told you enough stories about patients done wrong already in this class, and you'll hear more. So You really have a huge responsibility. Not to scare you, but to take it seriously and to be responsible. Look things up, learn, take the initiative. Okay, so when you break your humerus, it can happen in different areas, right? The neck of the humerus, the proximal humerus, lots of different areas. And then I have some photos here which show all the different possible ways you can fracture your humerus. The options are endless, right? Of different ways that the fracture can occur. But in general, and this I need to correct, and I forgot to correct in the slide, this should be active range of motion, okay? Because with fracture, we start with active range of motion first. If we start with passive range of motion, we could dislodge a fracture fragment, we could displace a stable fracture, and now the patient has to have surgery, right? Active range of motion, active first. Then passive. So I have these wrong, and I saw this already and I forgot to change it. So to err is human, right? These should be switched. I feel for you, Andrew. This cough, I've had it for like 3 weeks longer than you and I can't get rid of it.
Might be tuberculosis.
I got the bird flu. But again, in the beginning, you're going to do things for pain control. Your patient might be in a sling, right? And then we're going to start the getting the pendulum exercises going to get some activation, get some motion going, and get the scapula moving, right? I can work on elevation and depression, protraction and retraction with my scapula, and then I'm going to start, and the doctor's going to give you orders. Of what you should do. If you don't, call and ask, right? Should be active range of motion to start, and then working on more aggressive things as we go. Okay? If someone has surgical intervention, open reduction, internal fixation, right? It's usually plate fixation in the humerus with screws, and those stay in. And usually those patients can start moving earlier than the ones that didn't have surgery. Okay? And while I'm thinking of it, I just remembered that, Courtney, I have something for you, and I don't want to forget to give it to you, so see me after class. I just thought of it. Okay, mid-shaft fractures. I know I have something in here about radial nerve. Yes. 20% of all closed fractures of the humeral shaft, radial nerve pathology. These again are from fall or some high energy accident. These could be treated with a sling or the mid-fracture or the fracture brace that I was describing, that would be a cylindrical brace or a clamshell type of brace. These take a little bit longer to heal. Sometimes if it's more distal humeral injury, you'll have a hinged elbow brace that will lock elbow motion to only a certain amount of motion. They may not want full elbow extension or full elbow flexion to impact the healing of the distal aspect of the humerus. So they'll put them in a humeral fracture brace, and they have just a pin that you can control the motion that's allowed in the brace of that elbow. Okay. And then here are some treatment things with the mid-shaft. These are protocols that are straight from your book. Again, active range of motion first, passive range of motion second. Okay? Any questions about humeral fractures? I know we're kind of plowing these kind of quick, right? But I have some shoulder cases that we're going to work on today as a group. So that will be, follow up to kind of review all this information too. And then shoulder arthroplasty. What does arthroplasty mean? Replacement. Arthrodesis, fusion, right? Arthrodesis, fusion. Arthroplasty, replacement. So shoulder arthroplasty, shoulder replacement. And this would typically happen because of some type of arthritic change that happens at the joint. No longer those smooth articular surfaces, right? And sometimes there's different types of arthroplasty. They also have a reverse shoulder replacement. Could be a partial hemiarthroplasty. So you've heard that term before in case-based, right? So shoulder arthroplasty. But the shoulder arthroplasty isn't as good as the hip or knee. You know, the hip and knee are very successful. My dad is out like working outside now. His surgery was January 21st, something like that. And he's doing great. He's having his other knee operated on next month. So that's how successful shoulder or knee and hip replacements are. Shoulder replacements are a salvage procedure, not something you could jump into, not something that you can return to heavy labor work with, right? To decrease pain and restore function. Very commonly, patients don't get full range of motion back and full strength. That's when it's really, really bad and you can't live with it anymore and you can't use your arm. You get a shoulder replacement and you get hopefully some function, some motion back, but usually not full. Salvage procedure. And then this is the protocol for shoulder arthroplasty. But again, if you're treating a patient with shoulder arthroplasty, you're going to call the physician and get their protocol, get directions for this case, right? But now this, with arthroplasty, they disrupt tendon, right? So now we're switching back, starting with passive range of motion first. And I could have a stability issue, so I'm not going to allow full external rotation, just like with the labrum tears, all right? I want it to be tight a little bit. So I'm not originally going to allow full external rotation, or they might not even allow me full flexion. And then I can get greater as time goes on. Again, when you're a new person, they're not going to give you a shoulder arthroplasty out the door, because that's related to tendon repair and all kinds of things like that. So it's going to be something that you would get when you get a little bit more experience. Hopefully is the case. Okay? Again, you want to get, whenever you're working with the shoulder, you want to make sure you include the glenohumeral and the scapula. You have to do both. If you only do half, you're only doing half of the care that they need, and they still won't get all the function back. And the capsule has folds, which we talked about when we talked about frozen shoulder. The capsule folds over itself when your arm is at its side and when it's internally rotated, so it gets scarred down. When your shoulder is moved out, those folds disappear, which is why it's difficult when you have shoulder stiffness to get full range of motion. Let me just see where we're at, because I'm not seeing the right. So what I want to talk about now is just treatment. And this is not really in your PowerPoint. But so we've gone through all these different diagnoses, right? And now we want to know, well, you tell me I can do active range of motion, but where do I start, right? You tell me that I can do passive range of motion, but where do I start? And how do I grade things, okay? So this is where what you learned long ago in functional assessment about changing the plane of motion comes into play. It's very, very important in the shoulder. When we eliminate gravity, we add gravity, we're against gravity. That's how we modify. And for those of you who are in the level 1 hand clinic, you've already had more experience with this. Those of you who haven't really heard a lot about this yet. But another thing, so when I first get my shoulder patient and I have orders to start active range of motion. Say it's a humeral fracture, okay? Mid-shaft humeral fracture, no radial nerve involvement, right? Thank God. And I have orders to start active range of motion. Do you think I could start with an occupational-based activity? Why not?
A lot of it's overhead.
A lot of occupational-based activities are overhead, right? Do you think the patient could lift their arm without anything in it? No. So why would you add something in? If they already can't lift just their arm, right? Why would you add? So this sounds very non-OT, right? I would probably be shot by some of my colleagues who would be hearing me say this, and I'm being recorded at the same time, right? But you cannot, this is something that you do not start with occupational-based activities. They can't even lift the weight of their own arm. If you put a water bottle in it, that just increases the weight, right? They're having fun next door, right? So what else could I do? If they could lift, say, I'm going to say 55 degrees, and they go like this. I say, let's check your active range of motion. Do you think their upper traps are weak?
No.
No! I'm moving my shoulder by using my upper traps, right? They are strong and on fire. Pain, right? They can't even lift their arm this way. So what do I do?
Did you stabilize right up, like?
I could give them a little cue, palpate the upper trap to say, let this muscle relax and try it again. And they do this. These are my clinic people raising their hand. Someone who wasn't in my clinic, Andrew.
Could you try putting him in side lying and do?
I could change gravity, right? I could put them in sideline and see if they can move. That's one way. Is there any other way? Anyone have another idea? Okay, clinic people. Jessica, you had your hand up.
I had sideline.
You had sideline. Aubrey?
I was thinking, yeah, remove gravity. Like,
Remove gravity.
either, yeah, sideline or even instead of lifting the arm upward, kind of move it forward from prone position.
From a prone position. Get them prone. Then I'm having a gravity assisted. Right? What a great way to get started is just do, your patient's going to be so happy, right? They can move this far. You put them prone and maybe they can get to 90. They're better in one visit, right? Get your patients prone and get them, so don't just keep on working on this. If you keep doing this with active range of motion, all you're going to do is fire up more of that upper trap. They're going to hate coming to therapy, and they're not going to come back. It's not the right thing. They'll never get it. Never get it, right? Get them in prone, use gravity to assist, okay? Yeah.
You could also start with isometrics where you don't have to move as far, or do active
But with the
assist.
fracture, I may not be able to do isometrics.
You could do active assist as well.
I might be able to do active assist, but if I have only orders for active range of motion, that means no active assist. That means no passive. That means no isometrics because the fracture isn't healed enough. So you have to make sure you look at the script. Okay? What I also want to talk about is in this curriculum, you don't learn about open chain exercises and closed chain exercises. And the PTs spend days on this. They probably have a whole class on open chain and closed chain, which is why they're stealing all these shoulder patients, right? So we have to learn this. We have to learn this information. It's all about grading activity. If you just keep, like I said, having the patient do this over and over, they're never going to get it. You have to make it simpler, okay? So an open chain exercise means that my distal extremity has nothing attached to it, okay? So raising my arm in this way is an open chain exercise. It's unsuccessful. They're having pain, they're moving in an awkward position. I tell them to try harder and they, oh, I'm having so much pain, right? You can't keep working in that way. You have to change gravity, okay? So maybe I changed gravity and I put them in prone, like Aubrey said, right? And they can get to here, but they can't get any further, okay? It's still open chain exercise. I then can grade the exercise easier to an easier exercise by closing the chain, okay? The way I close the chain is I put something on my distal extremity to make it easier to move. So if I'm in, I move, my patient was doing this, right, unsuccessful. I put them prone, which was the right thing to do. They can get to 90 with gravity's help, but they can't get any further. They can't do better, so I'm gonna close the chain, all right? I'm gonna put a ball on their hand, and they can push further with the ball. I closed the chain, and that made it easier for them to move, okay? So I first moved them prone, gravity helped me. They couldn't get further. I had to make it easier. I have to close the chain, put a ball underneath it. They're moving good, okay? They're moving good in this way. Now what do? They're doing V's, they're moving out in abduction, they're doing circles, clockwise, counterclockwise. They're moving all out in a prone position with the closed chain.
Sideline would be more difficult.
I can move them to sideline, right? I move them to sideline, and I try to have them do it this way. They can't do it. What do? Close the chain, right? Get that ball in sideline, right? Have them move the ball in sideline. Okay? They get good this way in I'm sideline. I'm really not, right? They get good in this way, right? Then what do? Go to supine? I'm going against gravity? Go back to prone and do what? I could open the chain and have them just move this way. Yep. Okay, so I put them back to prone, and they have good active range of motion this way. What do I do next? I could go sideline, open chain. They're doing good this way. So I want to try against gravity. Standing. So I have them stand, and I have them lift, and they do this again. Close the chain, right? So I could take that ball, I could start on the table. Moving this way, right? I could then move to the wall. Keeping my chain closed. This way, right? When they get good this way with the ball, I take away the ball, keep it closed, put a towel. Keeping it closed. And then when they get good this way, I'm going to start active. Do you see all the baby steps that you have to do when you can do this? Right? It's a series of grading gravity and opening and closing the chain. If people are moving in a dysfunctional way, don't let them keep moving in a dysfunctional way. Change gravity, close the chain. Okay, does that make sense? So the reason why OTs aren't treating shoulders is because they don't learn that. It's not that hard, right? You just got to use your clinical reasoning, think about it, what's harder, what's easier, and opening the chain and closing the chain. There's lots of different ways to close the chain. Scrubbing on the table, I could even scrub with the ball, I could change to scrubbing the table, I could do some kind of an incline board, all kinds of things you could do. Finger ladders, up the wall. I'm not a huge fan because you gotta go to the next one and then you're not really closing the chain the whole way. But
Where does that terminology come from? Like, I don't get the connection, like close the chain.
my chain is open. I'm not interacting with anything, and as soon as I touch something,
Okay.
I close the chain. Like if someone can't get knee flexion, right? Back to my dad's knee replacement, right? He could do knee exercises all day and he's not going to get more motion. But if he closes the chain and he puts his weight into it, he's going to get more of a stretch, right? And that is the reason why PTs are not primarily hand therapists. Because is it easy to close the chain in a finger? No. It doesn't. And that's what they know. Strengthen things, grade gravity, and open and close the chain. Right? That's how they treat the hip, the knee, the foot, the shoulder. Right? The hand has to be treated differently. It doesn't matter if my hand's placed here, or here, or here, or here, on how it moves. Does it matter for you, Susie, how your wrist is, if it's here, or here, or here? Like, whether you're holding on to something or not. It doesn't make a difference. That's why we have maintained that control of the hand therapy world, right? But the shoulders have been taken over by the PTs because we don't learn about opening and closing chains. And we learned the very first semester about gravity. And then we got to learn about mental health and cognition and visual perception dysfunction and all the different areas that OTs work, right? That we're losing this huge diagnosis of patients. Or, worse, we're mistreating this huge diagnosis of patients in an inpatient rehab. So, figure out how to open and close the chain and how to change gravity. And don't start, and passive range of motion has to be done with your patient in supine if you can get them in supine. Don't do it with the patient sitting. Get your patient in supine for passive range of motion if you can. Okay? And active range of motion, change gravity, change the open between open and change up. Open and close chain exercises. And then I just want to show you some joint mobilizations to the shoulder. Okay? You haven't learned those before either, right? I hate to bother you guys, and you have food here. Can we have Shabani lay on this table? Or actually, that's clear back there, and you guys can probably all see. Anyone, can you just scooch down and we'll have Shabani here, because it would be good to be on the end. Sorry. Do you mind doing it? Okay. Hop up. So, with joint mobilizations, it's kind of confusing because when you think of posterior glides, you think, oh, I want to be on the posterior aspect of her shoulder, right? But what it's describing is where we're pushing the head of the humerus, right? So if you'll scooch over just, I don't know the best way, I'll go on both sides. So I'm going to hold her humerus. Whenever you do a mobilization on something, whether it's a finger, a shoulder, an elbow, you want to open the joint space. I can pull Shivani right off the table. She's got a slippery shirt on. I want to distract the joint, okay? The worst thing you would do would be to compress the joint and then you crunch, right? Especially if your patient's like 55 and is an electrician. They probably have some arthritic changes in their joint, and you just close that space and went crunch, right? So you want to distract the joint, put your hand over the humerus, and you posteriorly glide it. And she's not really relaxed, I think because I'm pulling her off the table. And for some reason, like this whole rocking the baby, just as soon as I rocked her little arm, relaxed, right? It's not a big motion, right? Posterior glides. So if your patient has a problem with flexion and internal rotation, posterior glides. Okay, and usually it feels good, right? And then I can do an anterior glide to increase shoulder external rotation. Again, I'm going to distract the joint. My hand's going to be on the head of the humerus, and I do, and yeah, we're rocking the whole table, right? So it's firm, but not forceful. Could you guys see on this side too? Yeah, do you mind just switching over to this side a little bit? So, and it's another thing, like I hold my patients, like
they have a hurt wing, right? I don't want to hold them like this. Would she be comfortable? Would she be able to relax for me to glide her? I am like holding my patients. I am up close and personal with my patients, and I'm going to glide her shoulder. And when I do passive range of motion, she's injured. I'm not going to hold her like this. She will not relax. I'm going to hold her maybe initially like this, right? And I might just start motion like this. I have her arm, it's not going anywhere, and she's going to relax, right? And I'm moving, and we're having conversation. I'm using my therapeutic use of self, right? And I'm going to slowly get her shoulder to move. But if she does not relax, there's no sense in doing tug of war with your patient. Did we talk about this already last week? I talked about holding on to something. Yeah. So if you go to do passive range of motion and they can't relax, don't do it. Take the control back to your patient, put them on something to give them control to move. But hold them. And then after you stretch them, don't right back down. Pain. Let them gradually, come back down, holding them. I'm having a lot of physical contact with this arm. I can't hold it like it's another thing, right? Like you have to hold it like this. Hold it. And that's another reason why you can't really do it too in sitting, because you can't support your patient well enough in sitting. You have to, and I use my whole body, like I'm moving with it. I'm not doing this. Do you feel the difference in how supported you feel? Yeah, I'm going to move it like this. Okay? And I'm going to work on things. And with the shoulder, think too, do you think that's very comfortable to work on like this? No. Work in this plane of scaption. It's in between flexion and abduction is a scaption plane. And this is where we start working that's comfortable. Maybe I'll start in flexion first. And I'm going to work out to scaption. But I'm not going to work out here. Instability, right? Uncomfortable for your patient. So make sure that they're always forward when you're stretching them. You may have to raise and lower the mat, if you have that ability. If the mat's too high, you're going to be more apt to hold them back here. Okay? Thank you. Thank you. So, joint mobilization. That's it for the shoulder. It's a lot of information. You get 2 hours on the shoulder. The PTs get, 2 semesters. So that's why we have to do our homework on this diagnosis and to do the right thing. Go to extra classes on the shoulder. Did we talk about rhythmic stabilization? So here's another thing you could do. Like say that I'm grading activity and my patient can't do a lot of active motion, but I can do strengthening. So say that Shivani is sidelined on this side. I can have her hold her arm up and hold up. Now let me push you down. And I can do strengthening, doing rhythmic stabilization exercises where she has to strengthen everything by co-contracting it, and she doesn't know where I'm going to go, right? And I can strengthen this without painful movement. And you can do that, you can grade that in all kinds of ways. Rhythmic stabilization exercises. Rhythmic. Like the rhythm of the music. Rhythmic stabilization. Lots of different ways that you can grade that. But shoulders are super fun to work with. They're challenging. You have to think creatively to how to get them to move. And we have the whole occupation piece to go with it. So, in my opinion, we should learn more about shoulders in this curriculum, in every curriculum, but you have so much to learn when you're here. So what has to happen is you have to learn it some here, keep learning it on your own if you end up in that field. If you work in pediatrics, you're not going to need to know this. Mental health, everywhere else, Yeah. Yep, you will. Okay, let's take a break, and then we'll start the next talk. And 54-year-old male electrician, shoulder pain, impingement in the right shoulder, right hand dominant, complains of pain in the lateral humeral region when asked to point to where the region of discomfort, complains of difficulty sleeping, and reports the pain at night is 8 out of 10, which is causing him to wake up. So that's pretty significant, right? His pain during the day is also significant, 6 out of 10. Upon evaluation, patient demonstrates full passive range of motion to the shoulder with pain at the end range, and 94 degrees of active inflection, 73 AB, 23 ER, and 42 IR. And his wife says his shoulder bone sticks out when she sees him take off his shirt. What do you guys think? What are you going to assess? Well, we already know we assessed active and passive range of motion. And pain.
And pain. Posture.
Posture.
And
Because it's pretty much going to observe them too with during initial evaluation and see.
So we're going to check out the shoulder, see what his posture like,
Yeah, the
and
position of
observe
it.
for asymmetry. What else are you going to evaluate?
grip strength.
I would want to check grip strength, yeah. Can we show Allison, you want to show your shoulders?
I can show my shoulders.
This is the perfect segue into Allison. Can you take your jacket off?
Yeah.
So after class last week, Allison was saying something about her shoulders having problems. So
Well, now we're gonna have to.
we'll look. Okay. So look at her in standing, right? Do we have any asymmetry? Yeah. Elevated here. What about protracted? Is she protracted or retracted?
Not so much.
I don't see so much, no? But she's elevated. Now we're going to say, I want you to move your arms slowly up and down, and we're going to watch.
All right, get ready.
So watch, she's upwardly rotating. She comes back down. Whoa.
I was like trying to watch it in the mirror last week, and I was like, okay.
Yeah, you can't see it in the mirror. Okay, show her again. Going. And I usually have people do it like 5 times. Yeah, keep going. Do you guys see it? Oh, it's getting worse. Keep going. Does it hurt?
Yeah. No, it hurt last week after doing it a bunch with you guys.
Okay, so let's do this last time. Do you see? Every time she does it, it's worsening and worsening and worsening, right?
Yeah.
What do we think? Look at it. I could cup it, right?
They've always kind of stuck out like that. But
Yeah.
You can even see, like, near the top, you can even see it has a, yeah, right there.
It
has a
does.
weird
Once
roll.
Yeah. Yeah.
Like almost like a lump.
So I'd also want to check her pecs, right? To look for pec tightness, because she might be tight pecs both sides. Which, so she has asymmetry, but she's got problems in both sides. But now look at her. So she looked pretty good standing before, right? Then we had her do range of motion. Now look at her. Right? Because she's so weak. Now she's dying. She's statically winging. This is scapular winging. See? So in this case, his bone sticks out when he takes off his shirt. I'm going to worry about scapular winging. So in an orthopedic patient, because she hasn't had any, that we know of, any neurological dysfunction, right? Like a stroke or traumatic brain injury, right? What would we say would be the muscle that would be the culprit with scapular winging?
Subscapularis, serratus anterior.
Serratus anterior with orthopedic situations. So I want to assess this guy's serratus anterior strength, and I want to look what he's moving. Now I'm just going to have her do it one time. Does anyone have anything else heavy? Yours is open and mine's not. So and yours is cold, mine is warm. So let's put we'll put this here. Yours is they're about the same weight. And hold this out, and now let's watch her. So we weighted her. So go up, and then back down. And it should worsen. I mean, these aren't too heavy, you know. It should worsen when you weight it. So even if you evaluated someone and it wasn't this glaring as winging, you thought maybe it's winging a little bit, weight it, put a couple pounds in her hand and have her do it again and then see if you can create it. Because there's not much we do in our life other than maybe cheerleading or aerobics where we're not holding on to something, right? Everything else, we're doing something with function, so we're weighting our arms. So it may not show without holding something.
Would you recommend her not to stand like that? Because she's stretching out.
Yeah.
I mean, it looks worse when she stands like that.
It does look
Better when
worse.
she-
It doesn't matter. The problem is that she needs to strengthen her scapular stabilization muscles, right? And if I were to just check her real quick, remember how we assess? Can you put your arm on the edge of the table?
Yeah.
So this one was worse, yeah, but you can't see very well. But I'm going to have her do a bucket lift. Hold it up
Oh, yeah,
there.
get ready, you guys. Maybe so pathetic.
It's actually not too bad, okay? Mid-trap is going to be bad. Yeah, she's winging
I'm trying
when
so
I
hard.
even made a muscle tester. And now, low trap,
That was sad.
Sad. So we need to get her a home program pronto, or when she has level 2 student, she's going to be coming back here for therapy. She's going to have a partial tear rotator cuff because her scapulas are not stable for overhead reach.
Would you like compare that to her other side to see like her normal? Because like how do you know
She doesn't
if
have a
she's
normal.
just not stronger? Like if you're not
Okay, you come up here. Come up here. You're not winging. Come up here.
I'm just saying like what if your patient like isn't
I
as
know.
strong? How do you know?
And you're going to think about that. You're evaluating someone who's 83 versus someone who's, how old are you?
25.
Would you expect her to have normal strength?
Yeah.
Yeah.
But
So
I mean still like some people are stronger than others.
let's hold this up. Hold this up. Okay. You ready? Hold it up. Can I break her? How old are you? 23. And you're smaller than I could probably take you easier, right? I couldn't break you. Right? I don't want to do it again to poor Allison, but I could have done it with a finger.
Okay. But I don't know how you're.
I can lift babies though.
Yeah. But they're all right here with your internal rotators and your adductors, right?
Yeah.
So, yeah, don't sit down. But we saw that yesterday, and this is a good opportunity to show that. Okay, so what else are you guys going to assess with this guy besides his serratus? You might want to weight his shoulder when he's moving to check for sure winging, right? And then, so what about treatment?
We're trying to figure that out. We weren't really quite sure.
So we know he has impingement, right? And we suspect that his serratus is weak. How would we strengthen the serratus anterior? Do we know how to do that?
Punch-ups.
Punch-ups. But if you don't know, there's like a million ways to strengthen the serratus anterior. But just lying in supine and having you punch up to the ceiling in this way will strengthen the serratus anterior.
Yeah, fucking up that.
We want to strengthen the serratus anterior for sure. We know he has impingement. When people have impingement, what is the root typically?
Weak external rotators.
That's pressing against the nerves causing.
Does the nerve have anything to do with impingement? No.
Weakness of the external rotators.
Weakness of external rotators. And what did you say? Postural asymmetry, right? So we want to improve his posture, strengthen. Because what do we think is the future for poor Allison?
We'll be seeing her in the clinic.
We'll be seeing her in the clinic. We'll wait till she's about 35. She's going to have a rotator cuff tear.
My mom just got hers repaired like a month ago. My dad had his a year ago before that. So.
Oh, yeah. So someone should get Allison a home program, right? So we're going to strengthen the scapular stabilization muscles, look at the posture, strengthen serratus, check pecs, because what's weak, the opposite's tight, right? How do we stretch pecs?
I like to stretch my pecs on the door. Like,
Yep, you can do a door jam like this. This is the easiest way. Then here, then here, right? You could do it in a corner. You could have them lie supine, put a towel rolled on their back, push from anterior in the clinic. You could have them lie just on a towel roll on the floor at home to stretch pecs. How do we strengthen scapular stabilization muscles? How do we strengthen, anyone know? My clinic people all know. So I want to do external rotation. How do I strengthen my external rotators?
Like that or like that.
Is this, which way should I start? This way or this way? This way. Unstable, right? Higher level, easier, right? So how will I, is this strengthening my external rotators? Maybe a little in the beginning. So sometimes it's like with my rotator cuff people tears, I call it a tennis swing. Just practice like you're swinging a tennis racket, just to get started, right?
Do you suggest like slight rotation in the torso so they're not,
No, I want external rotation.
like, I mean,
Like this?
not that much?
Yeah. No, I want external rotation. I could put them in sideline and make it against gravity, right? I could add a weight. I could do isometrics. I could do TheraBand. I could hold a can of peas. You just want to strengthen external rotation. Do you remember anything from Anna from clinic about strengthening the scapular stabilization muscles? I don't know if you had any shoulder patients. Chicken wing. Chicken wing is one way to strengthen low trap. And anytime you're reaching overhead, you're strengthening low trap. So chicken wing. Did we go over this in class already? No. Is, because I teach two sections, and I don't remember what I said in one and what I didn't put together. So holding here, okay? Here. And the first way to do it is to palm down and lift the elbow. Chicken wing. Okay? To make it harder, put the thumb up. Do it. Okay? To make it harder again, lift the elbow, lift the hand, drop the hand, drop the elbow. And it would be interesting to watch our friend here try to do that exercise. It would be interesting. Chicken wing. And then wall slide. Anytime you reach overhead, this is a closed chain exercise, but it's a way to strengthen low trap. Wall slides. You can advance it by doing this. Okay? Rhythmic stabilization exercises. The options are endless, right? There's a million ways to strengthen everything. Making circles. Lots of different things. What about sleep? Do you have any ideas for sleep for your guy? He has impingement syndrome. He's waking up at night. We would like to decrease pain so he can sleep through the night, because how are we when we don't sleep? Not good, right? So that's a critical thing, that you want to give him something day one so that he can sleep better. Do you guys have any ideas?
I want to know what position he's sleeping in.
So you might want to know what position he's sleeping in, but what would be the ideal position?
Would you put a pillow underneath his
Put a pillow under, because remember that when they repair the rotator cuff for the supraspinatus, they put a pillow under it to put the shoulder at a slack, right? Same thing, have them put a little pillow underneath, put the slack on the supraspinatus. Usually your patients can sleep through the night, and they will love you, right? Because when you can't sleep, you're miserable. Okay, we got to move on because it's almost 11 and we have a lot to do. Let's say the back group. 78-year-old female lives alone, midshaft humeral fracture, dominant side. She's in a sling for 4 weeks. Now is allowed active and passive motion 3 times a week for 6 weeks. She cannot sleep at night. She's currently sleeping in a recliner. A lot of shoulder patients cannot sleep at night in their bed. limitations in all aspects of ADL, and is frustrated with pain. She also reports that she has weakness when trying to eat with a fork and brush her teeth. What are we thinking, guys?
We're gonna do a range of motion assessment, just active range of motion.
So we're going to assess active range of motion,
Check the radial nerve with wrist extension, MP extension, MMT.
check the radial nerve.
Task analysis.
Do you think she's going to have radial nerve pathology?
20% chance.
She's no weakness.
Definitely maybe.
She says she has trouble eating with a fork and brushing her teeth. Should she have that with a humeral shaft fracture? With just the fracture? Because I can brush my teeth without even hardly moving my shoulder, right? So look at you need for that motion though, right?
Right.
Wrist extension. So absolutely, check the radial nerve. What else? We're going to do, would you do passive range of motion assessment?
No.
You have orders for passive and active range of motion.
Actually,
Yeah, assess passive too, because you want to know how she's doing.
Scapula movement.
Get the scapula moving. What else do you want to do? What if you note that she has radial nerve pathology and she can't extend her wrist fully? Splint it. What if she doesn't have good MP extension either? How are we gonna? Outrigger. She needs an outrigger with the wrist cock up. Yeah. Okay, good. And patients for sleep with this problem, you know, it's just hard. You just got to work with people to try to find a way. Sometimes people sleep on the side, so teaching them even to protract the scapula and sleep back here instead of on the side can help. Even if they put a pillow behind them so they're kind of rolled back on their side, sometimes will help. If they have to sleep on. Some people are like, I have to sleep on that side. I can't sleep on the other side, you know? Okay, number 3, you guys in the back. 45-year-old female, works as a hairstylist, comes to the clinic with a script from her family doc with shoulder pain, Eval&Trx. She has gotten progressively worse, limits in her ability to fasten her bra, tuck in her shirt, and perform overhead tasks. She has limitations with active motion in the shoulder, but presents with full passive. What are we thinking?
It's a strength problem.
It's a strength problem.
There's issues with external rotation and overhead issues.
Right, so what are we thinking? It's likely. Rotator cuff, yeah. And look at what she does all day, right? Yeah. Yep, holds blow dryer. And here's a way, the way that we assess for rotator cuff pathology, one way, there's a million tests. You can get any shoulder book and you'll see a whole grocery list of assessments you can test for different pathology. We would have needed 3 more days to go over it all. Empty can test, will that see if I turn it over?
No.
Like emptying a can, right? And then raising up will create significant pain if it's impingement or rotator cuff pathology. That's one of the things that we do. So like you described, blow drying hair, right? All kinds of that. Or even cutting. All right. 45-year-old, 63-year-old female who's retired, active with her grandchildren. She presents to the clinic with a script for therapy 3 times per week for 4 weeks, frozen shoulder. She indicates the doctor told her she does not go, the therapy does not work. She'll have to have manipulation. She demonstrates limitations in both active and passive during the eval. Pain, 10 out of 10. And patient is guarding with motion and apprehensive to try therapy. So do you think she's going to be a great, easy patient? No. No. So what do you think we should start with? So we're going to eval, we've already evaled active and passive. Or not, what does it say here? But we know we would eval active and passive. Sometimes when patients are really guarding, their active might be better than their passive because they're not letting you take their arm, right? What else do we want to eval?
We want to
Look at posture, asymmetry, stability. What else? Do I want to do median muscle tests on her, do you think? will she come back if you do medial muscle test? No. She has a pain of 10 out of 10. If you do medial muscle test on her, she's not coming back. She's not coming back. You just lost a patient. So I thought I talked about this in class last week, but I didn't. So one thing you can do if your patient is guarding, if I try to do passive range of motion with her, it's going to be tug of war. She's going to be in pain. She's not coming back. So if a patient is guarding, you have to give the control to the patient, okay? So you have to find some way to get them to move their shoulder. And I don't have anything good here. You have to find a surface that's just the right height. So if I take this, oh, there's some ADL equipment in here. I don't think that's supposed to go in here. Here's an enlarged handled spoon, and a highlighter, a bowl, a shirt, and a universal cuff. Okay. If I take this and I get something at a higher level, like maybe she can move to here, and that's what she's got. If I just have her step back, I'm creating shoulder motion, right? I'm giving her control. And this is what I did with your guy from the heart side.
Oh.
I didn't do passive range of motion with him initially. He was guarding. He was not comfortable giving him my arm. I did this. And then once he gets this good, I can take a step back, right? I can take a step back and get shoulder motion. I can take a step way back when I get better. And your patients can do this at home. I can go side to side, right? I can do, someone just asked me about horizontal abduction and adduction, right? I can do abduction. If I go too far, I want the thumb up so I don't create impingement, right? I give my control to my patient, let them push their own arm with that kind of patient. All right, I can do scapular stuff and do all that stuff. Think she'll be able to do pendulum very well? No, no. Okay, is this helpful? All right, last patient, 83-year-old female who comes to the clinic with diagnosis of shoulder pain, eval, treat, strengthening, range of motion, stretch, home exercise programs, because the doctor doesn't know what to do, they tell you to do everything, right? 2 times the work for 4 weeks. The patient reports that she is retired, spends most of her time at the casino. This is actually my mother-in-law, playing the slots. She complains of pain in the anterior aspect of her shoulder. She has pain with all ADL and home management tasks, and she's a 2-pack-a-day smoker, poor posture.
Deliberated a lot on it. Like first we went, so it could be arthritis.
Could be arthritis because she's 83,
And
right?
then we looked at different injuries to a joint, but it didn't get any dislocation back.
Right.
So looking, the horse for one of these is biceps tendonitis, and she's doing a lot of this.
That's exactly right. That's exactly what I was thinking when I wrote the case. Because think of what she's doing at the casino. I mean, either the handle or the button. The button, right? How do we sit in a casino? I don't go to casinos, but how do we sit in a casino?
You're slack on a
You're on a stool without a back, right? Hunched over, crossing your legs, right? Poor posture. You're creating pathology for biceps.
She's doing a lot of time like this.
And she's a 2-pack-a-day smoker. Lots of puffing, right? 83, poor circulation. Also because she's a smoker, poor circulation. And do you think she's got a lot of activity in her life if she's smoking and gambling the whole time? Think she does a lot of cardio?
Walking around the casino.
No, she's got valet because she goes there every day. So she's got the valet parking. Okay, so I'm going to palpate her biceps tendon, right? And then if there's pathology here, there's a problem in the back. So address that.
So we're going to want to rest the tendon, work on healing, and then strengthening.
Absolutely. Rest the bicep tendon, strengthen the back. We don't do anything back here, right? Just the yoga pose, whatever that's called, where you lift when you're prone.
Oh, isn't that like the?
I don't know all the names of the poses I go, but I don't remember the names. All right. Any questions about these? You good? Okay. I know I'm like fast and furious, but we got to keep going because we still have a lot of content to cover. Are you guys okay with moving forward with shoulders or any with fractures? Okay. We'll just go to 11:30 and we'll stop. Follow up next time. So with this, we're going to move distal down the extremity and cover the rest of the hand, okay? We already talked about this. I knew I had a picture somewhere in this class of this. What do we see here?
Pediatric.
A pediatric hand, right? And why do we know it's a pediatric hand?
3 carpal bones.
He's missing some carpal bones, right? And how old do we think this kiddo is? 3, yeah. And what else do we note about the location of the growth plates? Remember, the growth plates are proximal in some areas and distal in others, right? Can we do ultrasound over a growth plate?
No.
No. Contraindication. And then just so you see, there's a pilon fracture of the distal phalanx of the thumb and the index finger. Must have gotten crushed during a pinching activity or something. Or stepped on, something like that. What's that? Slammed the car door, or any kind of door. You know, kinds of things. Okay, so in looking at digit fractures, these are the occurrence of fractures. So you can see most commonly distal phalanx fractures, and then also metacarpal fractures. And if you fracture the ring and small finger metacarpal, that's called a boxer's fracture, because most commonly occurs from a punch. And the doctor that I used to work with said it was like 99.9% occurrence of a boy punching something because of a girl, something like that, because they get mad and they punch something. Boxer's fracture. Metacarpal fracture of the ring and small finger. And then less common would be fractures to the proximal phalanx and the middle phalanx, and we'll talk about that. And there's also a chart in your book, I don't think the page number is correct, but they have timelines on healing of all the different fractures. So if you ever have to question or look up how long it takes for a fracture to heal, that's a nice table in your book. So distal phalanx fractures could be either a tuft fracture in the shaft or articular. Have we talked about that? An articular fracture means that it crosses the joint space. So when a fracture says it's an articular fracture, that's more complicated because it can affect the joint alignment and the joint congruity, which if it's not aligned appropriately, could limit range of motion, could cause problems with arthritis later on development. So, lots of problems. Also, a lot of our tendons attach near the joint. So if it's an articular fracture, we might have a problem with tendon. So if I have a distal phalanx fracture that's articular with tendon avulsion, what do I get? Mallet finger. And if the bone comes off with it, it's called a bony mallet. Bony mallet. Tuft fractures are what was on that. Here's just a picture of different fractures. This would be a tuft fracture, the distal aspect of the distal phalanx. And then you could have a mid-shaft fracture, which could be transverse. You could have a horizontal. I mean, opposite what I just said. And then this is also a picture of a tuft fracture. It's kind of hard to see. My daughter had a tuft fracture. She was sitting, crisscross applesauce with her hands back, and another kid stepped on her hand. Tuft fracture.
But if you look, these heal pretty quickly, right? You put them in a splint, which would be this type of splint, for 3 weeks. By then, they should be less painful, and then you should usually be able to take the splint off. If it's really super painful still, I need to leave it back on for another week, but the doctor makes that call. But usually they heal really easily. It's a good fracture to have, good outcome, doesn't affect tendon or motion usually. Splint it for a little bit of a time, and you're fine. My daughter was fine, splint for 3 weeks. One thing that happens though, when you look at these tuft fractures, frequently involves the nail bed because they frequently happen from a crush, like in the door, the car, closet doors, and a lot of times in kids, because I don't know if you're around kids a lot, but kids are always like hiding from each other and jumping out and scaring and slamming them and or locking them out of their bedroom, don't come in here, right? And the kids put their hands up to block the door and slams their finger in the door. Lots of kids with injuries. I've had kids on those rocky things at the park, those little horsey things that rock, and they put their fingers in the spiral springy thing. Yeah, so they frequently have a nail bed injury that might be open with a wound, okay? So what are you thinking about if they have this nail bed injury with a wound, so they're covered with some kind of gauze, right? And you make this splint over top of it, what's going to happen? This is going to stick to the gauze. And I've had so many students do this. So don't do it. Your patient will hate you because their finger is on fire, okay? They stuck it in that springy thing, right? It's got a nail bed injury, fracture tip, one of the most sensitive areas in the body, right? Gauze on it, and the doctor says, put them in a digit protector splint. You make this, looks beautiful, stuck to the gauze. Can't get it off. And you're pulling on it. It's all covered, right? Very unhappy patient. How can I keep that splint from sticking to the gauze when I make it? Vaseline over it. What else? Wet paper towel. Do something. Put that in your notes because if you have to make this splint, and it's very painful for patients, don't put the splinting material directly on the gauze. If you have to do something else, like say they had a distal radius fracture and they had a gauze wrap on, they were all covered because they had their sutures taken out or something was going on, and if you make the splint over that, you can even just take a stockinette and then you can just cut it off and pull it off. There's lots of things you can do. But on these little finger things, it's stuck on there. And it's very painful to help to get it off.
If there is a wound though, would it, like the wetness of the paper towel affect the paper?
You're not going to leave it on there. You're going to make the splint, take it off, take the wet paper towel off, and then put the splint on. And I'm not talking soaking wet. Like squeeze all the liquid out, just wet enough so that it won't stick.
Oh, so the gauze only sticks when you're actually making the splint and not...
Only when you're making the splint. Only when you're making the splint. When it's cool, it's not going to stick to anything. So you don't put it on repeatedly, only when you're fabricating the splint. Then take it off, take wet paper towel out. If you put petroleum jelly or lotion on the gauze, you have to redo the outside layer. And you have to do it the same. If you make it now much bigger, your splint won't fit on, right? If you make it too less, it'll be too wiggly, it won't support the fracture. So it's got to be the same number of layers. Okay, so the shaft fracture can be either longitudinal or transverse, as in the picture, and then we talked about articular fractures, where it may create a mallet finger, which you're then adjusting or dealing with two fingers. Middle phalanx fractures are less common. The middle phalanx is a strong, short, squatty bone. So you're most likely to, if you fall or get injured with something, you're more likely to damage the soft tissue before the bone will break. Okay? You could either have a fracture that's transverse, oblique, on an angle, or intra-articular, and what does that mean? Involves the joint space, okay? Could be closed, non-displaced, they might just buddy tape it to the finger next to it, get back in the game and play, right? Or they might have to have open reduction, internal fixation with plates. Something else is people get unclear about all the, do we talk about the fixation, about plates usually stay in? Pins are not threaded, so they usually come out. Did we talk about this already? So plates and screws normally stay in with internal fixation. Pins are usually temporary because they're not threaded. They won't stay in. They're just temporarily there to secure a bone fragment or something, and then later they're taken out. Okay? With these patients, we want to put them in an intrinsic plus. Can anyone show me what an intrinsic plus position is? Yep. Intrinsic minus, right? Intrinsic plus position, because this actually uses soft tissue to help stabilize fractures, and we want them to be in a full PIP extension, because we don't want to get a contracture. Another thing is these fractures, I hate these fractures, they're really hard to treat, because if you had enough force to break the bone, it was a high energy injury. And the PIP has the largest arc of motion. So if you take your DIP joint and see how much the norms are, right? And then your PIP, if I just move it in isolation, it has a huge arc of motion as compared to the other joints in the finger. So it can cause a lot of loss of function with being able to hold small objects in your hand and that type of thing. They have to get moving right away, right? Big in capital letters, stiffness, if you have to immobilize for greater than 3 weeks. They're more likely to have soft tissue injury, right? What would be a soft tissue injury that would occur at the PIP joint? Central slip. How long do you have to immobilize the central slip?
6 weeks.
6 weeks. And what do we know about stiffness? So how easy, and the PIP has the largest arc of motion, how easy is it going to be to get that PIP back to normal? Not easy. Not easy. So I hate treating fracture with central slip injuries. They're a nightmare. Nightmare.
Do you assume that if they have this fracture, they have central slip?
No, you can't assume that.
So do they get like an MRI or CT that shows?
No, the doctor will just assess it and look for active PIP extensions. Isolated active PIP extension. If they can extend well. Manual muscle test it, right?
Even if it's broken?
If it depends on what's happening with the fracture. The doctor does this. We don't assess for PIP. Now, if they had a middle phalanx fracture and they saw a general orthopedic, do you think for sure they would pick up if the central slip was intact or not? No. So you already got the case that all hand patients, in my mind, should be treated by a hand surgeon. Right? How critical. So you see how many opportunities for mistreatment there are? Right? Okay. This is the last thing I'm going to talk about for today. And this is a big thing. Okay? This will be on the test. For sure. Okay? Because I had a situation where someone was treated inappropriately. So that's for sure the big things, right? Because there's so much soft tissue disruption with PIP injuries, it's more likely, right? So it's more likely that the PIP is going to dislocate before even. You might have a fracture with it, but it's very common to get PIP dislocations. Okay? The difference is that how you describe the dislocation is not the surface where the injury occurred, but it's where P2 moves in relationship to P1. P2 is the middle phalanx, P1 is the proximal phalanx, right? So when you think dorsal dislocation, you think, oh, the injury happened here. That is not where the injury happened. The injury is the volar plate, which is a soft tissue structure which keeps the finger from hyperextending too much. Volar plate. So the injury occurs volar, but the dislocation describes how P2 moves in relationship to P1. Okay? If you have a volar dislocation, it's a central slip injury because, again, it describes P2 in relationship to P1. They move against each other, okay? So when P2 moves volarly, that, if P2 drops down volarly, that creates the avulsion of the central slip off. Do you see what I'm saying? Central slip injury. Do you think you would treat these two things the same? Do you think you would treat them the opposite? So if you're not clear, will you do the right thing? No. You could really muck someone up. So I had a therapist, she had like 6 or 7 years of experience, and I was mentoring her in the clinic. Different location. She calls me and she says, and I can't now remember which one it was, because it was a long time ago, but she said, I think it was this one. She said, I have a volar dislocation with fracture, okay? And so she's like, I don't know what to do. What do I do? So I told her, that's a central slip injury. We have to hold it in full extension for 6 to 8 to 10 weeks, right? You have to splint them with the PIP in full extension, right? She didn't believe me. She's like, volar? That doesn't make any sense. It's a central slip injury. She splinted them as if it were a volar plate injury with the PIP in partial flexion. Will the central slip ever heal? No. Guess how long, this is a workman's compensation case. Guess how long it took me to figure out that she splinted them incorrectly?
Once she got to
Months, because it wasn't until she went on vacation that I went to the clinic and I covered her caseload for her, and I see this guy, and I look at the chart, and I see what she did, and she didn't do what I told her to do. She did the opposite. The wrong thing, right? So, never is going to get his finger straight. What's he going to develop? Boutonniere deformity. And guess what else? Went to high school with him.
Well, it's not your name that was on it.
I know, but this just drives me crazy.
Listen.
Yeah, it drives me crazy. So, there's more stories to tell. Wait. Okay, so here is the picture, but I want to make sure you're clear. Okay? Volar and dorsal dislocation is describing how P2 moves in relationship to P1, not the location of the injury. It's actually the opposite. So with a dorsal dislocation, you have a volar plate injury. Because you can see how this plunges through the volar plate, right? With a volar dislocation, this plunges up in relationship P2 and P1 and pulls off the central slip. It makes sense, right? But when you're not educated in what it really is, you hear volar, you think, oh, they disrupted the volar plate. It's actually a central slip injury. So I didn't name them, right? I think I maybe would have named them the opposite way to be more clear, right? But, so you have to know that. Any questions about dislocation? So with a dorsal dislocation and a volar plate injury, you splint them in slight flexion so they don't re-dislocate. Just like if you have a labrum tear, you don't move them into external rotation and abduction. You don't want them to re-dislocate. That's why you hold them in slight flexion, not for a long time, because if you immobilize it longer than 3 weeks, big stiffness, right? And I might put them in 3 degrees of flexion, and then increase them to 20, increase to 10, and the next week all the way straight, with the doctor's permission.
And then the volar, you said extension, split is.
Central slip injury, so has to be treated in full extension for at least 6 weeks. And they're going to have big time stiffness. Yeah. Okay, we have 5 more minutes. Let's keep going. I lied. Okay, that wasn't the last thing we were talking about. Let's just talk about metacarpal fractures. I'm sorry, proximal phalanx fractures, not metacarpal fractures. I have both slides showing up on my thing. The problem with the P1 fracture, and we talked about this when we talked about extensor tendon lacerations, that where P1 is, so large, the extensor tendon lies right, there's a lot of tendon to bone interface. The tendon lies right on the bone, so when you break the bone, scar forms, extrinsic healing occurs, latches on the tendon, and you get a tendon gliding issue very frequently with these fractures. Okay? Usually you splint in the intrinsic plus position, and that is because the sagittal bands help to stabilize the fracture. For P1 fractures and for metacarpal fractures, we splint in an intrinsic plus position. And then once you're allowed to, sometimes they'll let you, depending on where the fracture is it displaced, what's happening, they might have you put them in an MP block splint and let you do PIP motion, which you would want to do as early as you can because of the scar adhesion issue, right? Active motion will decrease the scar adhesion. All right, let's just talk about metacarpal fractures, and then we will save the elbow and the wrist for next week. We already talked about Boxer's fracture. It's a fracture of the metacarpal of the ring and small. Metacarpal fractures heal quick, 3 to 4 weeks most of the times. And they have a lot of what do I want to say? They leave room for not a good fixation or not a good alignment, and they still do pretty darn well. Okay? Usually they're splinted intrinsic plus, same reason, those whole sagittal bands. A lot of times they're not operated on because, again, they heal very well if it's not the perfect alignment. So if you have someone that has a metacarpal fracture, sometimes they'll make a fist and they'll say, I don't have my knuckle anymore on this side. And that's because it doesn't have the best alignment, but still, usually they're okay and they can do very, very well. So if you know anyone that has a metacarpal fracture, have them make a fist and look to see if you can see all the prominent metacarpal heads, because you may not be able to see them because of angulation of the bone. If you fracture the metacarpal of the thumb, we have to be concerned about a ligament injury. Remember we talked about the ulnar collateral ligament when we talked about arthritis? That can happen with a fracture to the metacarpal of the thumb. So we want to be concerned about that. And remember the very first day of class, and we talked about all of our fingers, when we move them individually, go to one point. Where do they go? Scaphoid. So with metacarpal fractures, when the patient can't move well, this is very commonly that the patient will think the doctor fixed their fingers crooked. But usually it's not, but it can be, right? So again, I have a story. I had a patient one time that had a metacarpal fracture, and she was diagnosed with complex regional pain syndrome. metacarpal fracture. She was a great patient though. She had great patient characteristics. She never missed therapy. She did everything I asked. Hard worker, stoic, you know. And as we started to get more range of motion, I noted pretty quickly that she was malrotated, which means her fracture healed with the bone rotated slightly. And 5 degrees of malrotation equals, which is not very much, 1.5 centimeters of overlap when the fingers come down into flexion, which is a huge functional implication and drives people crazy, right? So she had complex regional pain syndrome, so what treatment interventions did I use? Stress loading program, right? Scrub and carry, right? Did that. Did other things in the clinic, active and passive range of motion, gentle passive, because people that have complex regional pain syndrome, you don't want to do too aggressive, right? But she had this overlap, right? She was seen by a general orthopedic for her hand fracture. And so then she developed the complex regional pain syndrome, and she still had it. And so she wanted to get a second opinion. She initiated it. She was young, and she was active, and it drove her crazy that her finger overlapped the other finger. And her complex regional pain syndrome, although it was still present, was much better controlled once we worked in therapy. And so she asked me for a name of someone for a second opinion. And so when people do that, I give them a name, just like if someone were to ask me where to get a good, pair of shoes or whatever, So I gave her a name. And she saw the doc, and that was the doc that I was working with, so I was there in the clinic when she came. And the doctor's response to me was, "Are you crazy? You want me to operate on someone that has complex regional pain syndrome?" And so I begged, and he did. And the interesting thing, as soon as he repaired her malrotation, the complex regional pain syndrome went completely away. It's almost like your body knows, like, something's not right? As soon as he corrected the malrotation, she ended up getting full range of motion, no more complex regional pain syndrome, so she did great. But still, this can be a big problem with this malrotation. And then here is a picture of it, malrotation. I think hers was her right finger.
Does that only happen after surgery?
She didn't have surgery.
She didn't have surgery, okay.
She was treated conservatively with a cast. It was just allowed to heal, and she should have had surgery so that it wouldn't have healed in a malrotated position. Okay? So we'll end here on fixation terminology, and then we'll cover the wrist and the elbow next time.